Welcome back to Unintended Consequences, episode 32 for June 17th, 2026. We're looking at a case today where the people involved were doing their best with the information they had. António Egas Moniz won the 1949 Nobel Prize for the prefrontal lobotomy, a procedure that soon left tens of thousands with lasting cognitive damage. On a November morning in 1935, Moniz watched as a surgeon drilled two small holes into the skull of a 63-year-old woman at Lisbon's Santa Marta Hospital. The team injected alcohol into the white matter of her frontal lobes, the dense bundles of connecting fibers that link different regions within those lobes. Moniz had designed the operation to sever connections he believed were sustaining her severe anxiety and paranoia, essentially interrupting circuits that seemed locked into repetitive, distressing patterns. Within days, the patient appeared calmer and less consumed by her earlier fears. Yet she also showed reduced spontaneity and emotional range that never fully returned. Family members later noticed she initiated fewer conversations and responded with flatter affect even when events around her would ordinarily have prompted stronger reactions. That single procedure launched a medical intervention whose reach would far exceed the problem it set out to solve, because the same physical step that quieted acute distress also altered capacities that only became visible over longer periods. Moniz was a Portuguese neurologist already known for developing cerebral angiography, a technique that let physicians see blood vessels inside the brain by injecting contrast dye. He turned to psychosurgery because existing treatments for psychosis offered little relief once patients reached the point of sustained agitation or fixed delusions. Hospitals overflowed with patients whose agitation or delusions made daily life impossible, and staff often spent entire shifts simply preventing harm to the patients themselves or to those nearby. The only widely available options, prolonged sedation, insulin coma, or hydrotherapy, produced inconsistent results. Sedation could last days and leave people drowsy and disoriented. Insulin comas carried risks of prolonged unconsciousness, and hydrotherapy required equipment and staff time that many wards simply did not have. Drawing on earlier animal experiments and clinical reports of personality change after frontal lobe injuries, Moniz hypothesized that severing certain fiber tracts could interrupt the fixed patterns of thought seen in mental illness without eliminating the rest of mental life. He viewed the approach as a precise, localized intervention rather than a wholesale destruction of brain tissue, because the alcohol was aimed only at white matter connections rather than at the gray matter cell bodies themselves. In an era before antipsychotic medication, the possibility of returning even a fraction of institutionalized patients to functional life appeared both humane and urgently needed. Any intervention that might free up beds or reduce constant supervision looked worth attempting when the alternative was continued overcrowding and visible suffering. Moniz published his first series of 20 patients in 1936. He reported improvement in 14 cases with relatively few immediate deaths, and those numbers traveled fast because journals in both Europe and the United States reprinted the findings within months. Walter Freeman, a neurologist at George Washington University, adapted the technique into a simpler transorbital method that required no operating theater. An orbitoclast inserted above the eye could be performed in minutes under local anesthesia by tapping lightly through the thin orbital bone and then sweeping the instrument to cut the targeted fibers. By 1941, Freeman and neurosurgeon James Watts had performed hundreds of procedures across the United States, moving from a handful of trial cases to routine use in several institutions. State hospitals adopted the operation enthusiastically because it reduced overcrowding and disruptive behavior on wards. When patients stopped pacing or shouting for hours, staff could manage larger numbers without adding beds or night shifts. Professional meetings featured before and after photographs showing calmer patients sitting quietly, and some families publicly thanked physicians for restoring a measure of peace to households exhausted by chronic illness. because relatives could now visit without witnessing constant distress. The same indiscriminate cutting that reduced agitation also erased initiative, foresight, and in many cases, the ability to live independently, because the fiber tracts severed were not limited to those sustaining only the symptoms. They also carried signals required for planning sequences of actions or anticipating consequences. Follow-up studies from the late 1940s documented patients who could no longer hold jobs, manage households, or sustain meaningful conversation. One might still recognize family members, yet sit for hours without suggesting any activity or responding to changes in the room. Women received a disproportionate share of operations, and asylum records from several states show ratios exceeding 2-to-1, partly because female patients were more likely to be labeled difficult when they refused domestic routines that staff expected them to resume. Estimates compiled by the American Medical Association suggest roughly 50,000 lobotomies performed in the United States between 1936 and 1956. Even if the true figure sits a little lower or higher, the scale meant thousands of people experienced the procedure during those 2 decades. A subset of cases ended in death from hemorrhage or infection when the instrument nicked a blood vessel or bacteria entered through the entry point. Many more produced epilepsy, incontinence, or profound apathy, outcomes that appeared weeks or months later and therefore escaped the immediate post-operative counts. Because the procedure was irreversible and performed without controlled trials, each operation compounded uncertainty about long-term outcomes. Physicians could not later restore the severed tracts or run a comparison group to isolate which changes stemmed directly from the cuts. Families often discovered only afterward that reduced symptoms had come at the cost of an altered person whose needs simply shifted from psychiatric to custodial care, requiring supervision for basic daily decisions rather than for acute psychiatric episodes. The introduction of chlorpromazine in 1954 provided a reversible pharmacological alternative that could be started or stopped and whose effects could be observed dose by dose. It sharply reduced the number of new lobotomies within 3 years, as physicians saw they could manage agitation without permanent structural change. Freeman continued performing the transorbital variant until 1967, but most hospitals quietly withdrew support once the drug offered a less invasive option, and accumulating case reports made the personality losses harder to overlook. In 1962, the World Health Organization issued guidance discouraging psychosurgery except under strict research protocols, reflecting growing recognition that the earlier wave had occurred without systematic long-term tracking. The Nobel Foundation has never revoked Moniz's prize, citing the absence of any mechanism for rescission at the time of the award. The prize had already been given in 1949, before the scale of later outcomes was fully documented. Today, the procedure survives only in highly refined, image-guided forms used for a narrow set of treatment-resistant conditions, accompanied by ethics review boards that did not exist in the 1940s and that now require documentation of why less invasive options have already been exhausted. Interventions that alter complex systems without detailed causal maps tend to produce effects that cannot be confined to the intended target, because the tracts cut in the frontal lobes participate in multiple overlapping networks rather than in a single symptom pathway. When rapid relief from visible suffering is the dominant metric, slower or invisible harms receive less scrutiny until they accumulate at scale. The photographs of calmer patients at professional meetings captured one moment in time, but could not show whether those same patients would still be able to plan a week's meals or hold a conversation 2 years later. Modern equivalents appear whenever new technologies, whether pharmacological, surgical, or algorithmic, promise to simplify intractable human problems. The same pressure to act quickly can outrun the slower work of measuring secondary consequences that only become measurable after hundreds or thousands of cases. What safeguards would we want in place before similar, irreversible steps are taken today? That's unintended consequences for today. If this episode gave you something to think about, share it with a friend who'd appreciate the story. Subscribe wherever you listen, and we'll be back tomorrow with another case. And before you go, this show is part of the NARA Network, a family of daily podcasts covering tech, science, markets, and more. If you enjoyed today's episode, give OmniView a listen, a balanced daily world news briefing that takes every side seriously. You can explore the whole lineup at neuranetwork.com. This episode used AI voice synthesis of my voice. Editorial selection and analysis are my own.